unable to hear you.
Okay. Hello, I'm Dr. Angela Mosby, and I'm the Marketing Medical Director for CareNow, which is part of ACA Healthcare Systems and Sunrise Healthcare Systems. I've been practicing medicine 25 years, and I've been with ACA now for the past 2 years. I just wanted to point out a couple of points as far as urgent cares versus ERs and the necessity for freestanding ERs. Urgent care centers and freestanding emergency departments serve distinct but complementary roles in care. Care now has 20, soon to be 22 locations throughout the city to provide numerous access points to lower acuity care for patients. Urgent care centers provide efficient, cost-effective treatment for low to moderate acuity conditions, reducing unnecessary strain on hospital-based emergency departments. Freestanding EDs, or emergency departments, on the other hand, are equipped to manage higher acuity and time-sensitive conditions, offering critical emergency services in communities that may be geographically distant from traditional hospitals. Freestanding emergency rooms also offer the same care as the hospital-based ERs, with the same board-certified physicians and nurses providing the care. Together, these care settings create a tiered approach that aligns patients with appropriate level of care, improving outcomes, reducing wait times, and enhancing the overall patient experience. They play a pivotal role in decompressing overcrowded emergency rooms and preserving those resources for the most critical cases. Considering Las Vegas's population growth, the provider shortage, especially in primary care, and increasing healthcare demands, expanding and supporting both urgent care centers and freestanding emergency departments is not optional, but it is a necessity. Thank you.
Thank you. Let's see, next is Jackie.
Good afternoon. Can you hear me? Okay,
Yes.
great. I'm Jackie Van Blaricum. I'm with the Sunrise Health System, and today I'd like to share how we're investing in our network of non-emergent care along with the patient education and resources. I will also cover how we bill our patients, which we strongly believe represents best practice and should be the standard for every freestanding emergency room and micro hospital in the state. I'd like to begin with our network of urgent cares, which we are expanding at a significantly faster rate than our freestanding ERs. We are proud to have recently opened our 20th urgent care with several more in development. Today, approximately 75% of our access points are urgent care locations, meaning our urgent care footprint is 3 times the size of our freestanding ER network and will continue to grow to meet the non-emergent care needs of Nevadans across Clark County. Equally important, we have been intentional about how we build both urgent cares and freestanding ERs. These sites are strategically located in close proximity to one another to give patients convenient access to the appropriate level of care. For example, we recently opened our newest urgent care in Alante, within 1 mile of our ER at Alante. In other cases, such as our planned development in Inspirada later this year, both services will be located within the same business plaza. These 2 care settings are designed to work together, offering complementary options so patients can access the right care in the right place at the right time. In addition to access, we're continuing to enhance clarity for our patients at the point of care. This includes ongoing investments in exterior signage at all of our freestanding emergency rooms with larger illuminated ER identifiers to clearly distinguish these facilities. Combined with clear interior signage, patient-facing information, these efforts are designed to ensure patients fully understand when they're entering an emergency care setting. We've also implemented a free 24/7 nurse hotline to further support patient decision-making. These resources allow individuals to speak directly with the nurse who can assess symptoms in real time, triage any situation, and guide patients to the most appropriate level of care. In many cases, this includes helping patients safely manage symptoms at home when appropriate, alleviating unnecessary worry or directing them to the most convenient urgent care or emergency room when needed. Since its launch, the Nurse Line has already helped thousands of patients navigate their care options at no cost. Simultaneously, we continue to invest in community outreach and education to help the public better understand when to visit an ER versus an urgent care. We remain committed to expanding these efforts and would welcome the opportunity to partner with groups across our community, from Medicaid to commercial payers, to ensure members receive clear provider-led guidance on where to seek care. Lastly, it's important to highlight how we bill our patients, which we believe should be a standard practice for any freestanding emergency room or micro hospital. When a patient receives care at one of our freestanding ERs, they are billed the same exact rate as they would be at any one of our hospital-based emergency departments. They are treated by the same providers and receive the same level of care. Just as importantly, if a patient requires transfer to the main hospital for specialty services, they're not charged for the ambulance or not billed twice. This is the level of transparency and consistency we believe all providers should meet. We stand by our investments in non-emergent care, patient education, and resources, and thoughtful facility placement and transparent billing practice. We remain committed to partnering with the state and
Thank
other
you for your public
stakeholders
comment.
and respectfully request that any policy changes preserve
Thank you
emergency
very much.
capacity
Ma'am,
while
you're
setting
going over
appropriate
your time
statewide
limit.
standards for
Thank you.
signage, transparency, and transfer billing.
Jackie, thank you. You went over your time. Thank you. We're trying to get everyone. Go ahead. The
Thank
next one,
you.
Maddie.
Next comment, Richard.
Good afternoon, everybody. My name is Richard Henry, Henry. A long time in Las Vegas. I've lived here over 60 years. I'm a lieutenant with the local law enforcement academy, an agency. Also, I'm a director of corporate security for Las Vegas and a national company here in town. Right about February 18th, I woke up in the morning about 5 o'clock in the morning, felt pressure on my chest, walked downstairs, went away. I fell asleep for a little bit, woke up, I felt tremendous pressure on my chest, started sweating, called my wife upstairs. I said, get up, I'm having a heart attack. Immediately, I was within 4 miles from the emergency care center. 4 miles. Got there less than 5 minutes. Immediately walked in, put a cuff on, EKG, 4 baby aspirin, nitro. Immediately he knew I was having a heart attack. It was at about 90% blockage. They already called transport. They gave me morphine. I was getting transported right to the hospital. It was amazing how fast they were waiting for me. I went from the door to balloon in 68 minutes. If it wasn't for them being that effective, that fast with me being there, I wouldn't be here today. I train every day. I work out. I take care of myself. My last high stress physical with Dr. Danielian was a year and a half ago. I try to take care of myself and do my very best. But if it wasn't for that emergency care center being there, I wouldn't have made it. I know it for a fact. And being how close it is to my house, how effective it was for me to go to another hospital, and the distance from my house is a big deal. Then they had to call an ambulance in itself. They were waiting for me, and I was ready to go. I can't thank you enough for being that close, and all with Dr. Hawass and her team to save my life. And I thank you so very much. I wouldn't, in any other way, I wouldn't have it to have emergency care centers closer to homes. All right. Thank you very much.
Thank you very much. Next, we have Dr. Scherer.
Hi, this is Dr. Scott Shear. I'm a emergency medicine physician here in Las Vegas and work primarily at the freestanding emergency departments. I can go over multiple cases, including strokes where I've given TNKs, the clot busting drugs, STEMIs, just like the case that you just heard, trauma, but I'm just going to focus on one case. Case was a 35-year-old male patient, came in from home, which was actually right across the street from the freestanding emergency department. Patient had an obvious arterial laceration of his right upper extremity and a partial amputation. So the patient was immediately bedded, tourniquet was placed, IVs were started. Patient's blood pressure was low, so we had to start some blood. We got the patient transferred to Sunrise Trauma for definitive care in less than 30 minutes. Patient would have bled out in 3 to 5 minutes without having the care that he received so quickly. Thank you.
Thank you. Next up, Dr. Semsrott.
Hi, good afternoon. I'm Dr. Justin Semsrott, SEMPSROTT. I'm an emergency medicine physician, and I did my residency in Las Vegas in 2010 and have worked both in urban centers and rural places such as Yerington, Fallon, Winnemucca, and Elko, and have a lot of experience kind of across the breadth of Nevada, and now work exclusively at the freestandings. And similar to Dr. Shear, wanted to share one specific case that I had at one of the freestanding emergency departments where somebody was shot in the chest and his friends, if we can call them that, dropped him at the back door, banged on the door, and then drove away. And within moments, we were able to bring him inside. This was the middle of the night, only physician in the building with two nurses. And we're able to not only provide emergency stabilizing care for this gunshot wound to the chest, but we also had emergency blood that we were able to transfuse and stabilize and have him on an ambulance out the door and at Sunrise Hospital for definitive care within 45 minutes. And he was able to survive with no neurologic or permanent deficits. And he absolutely would have died without, if it was any further from a board certified emergency medicine physician. Thank you so much.
Thank you. Let's see, next up we have Dr. Kobier.
Hi, guys. My name is Dr. Alexander Colbert, Khob as in boy, EIR. I'm an emergency medicine physician, graduated residency in Michigan, moved to Las Vegas with my wife over the past year. I have a specific case in January. There was a softball tournament out of state. Everybody was here in Las Vegas. Gentleman, mid-30s, came in, blurry vision after being hit by a softball in the eye. Obvious proptosis, meaning the eye was popping out. Measured the pressures immediately. Pressures were 45, 47 through the roof. I had to do a lateral canthotomy on his right eye, meaning I had to cut the side open to relieve the pressure. There was blood behind the eye. I was able to get ophthalmology on the line. They were able to see him immediately. If it wasn't for the freestanding, he would have lost his vision. Thank you.
Hi, all. I just want to remind everyone, thank you for your testimony, to state who you're with. And if your hospital has already testified or someone from your organization, just given our time limit, we do want to get feedback on our study approach. So if you could just please limit it to one per organization and then submit any other comments to us by email. We'll put that in the chat. We will review those written comments as well. Thank you. Go ahead, Maddie, with the next person.
Thank you. Next up we have Dr. Yazdani.
Hi, I was just wondering, so I'm with Team Health, but a few other Team Health people spoke. However, I was a part of the ER at the lakes. So I just wanted to ask, should I hold off on sharing or should I share?
Has your organization already given their testimony?
There were other Team Health.
Yeah, if you could submit it in writing, I'm not trying to be a jerk. It's just we're trying to get through everyone, and so we can go through the
Sure,
study and get feedback. So if you can submit it in writing, that'd be helpful. Thank you.
All right, next up we have Dr. Evans.
Oh, hi. I am actually also part of Team Health. So I'll submit in writing. Thank you.
Great, thank you. Next is Crystal Turgis.
I'm with Team Health, so I'll submit it in writing.
Great, thank you. Stacy Sasso.
Hi, my name is Stacy Sasso, SASSO, and I'm the Executive Director for the Health Services Coalition. The HSC represents 27 union and employer-sponsored self-funded health plans, including public safety, gaming employers, municipalities, building trades, and hospitality workers, collectively covering approximately 300,000 residents of Southern Nevada. We're happy to see the Nevada Health Authority reviewing the impact of freestanding emergency rooms in Nevada. The HSC and their members have been increasingly concerned since the 2019 session when we brought this healthcare cost escalation to the legislature. Since we brought this issue forward, the number of these facilities in the South has grown from 5 to what will be 17 by the end of this year, a more than threefold increase. We also remain concerned that resources may be diverted to those facilities, causing longer wait times at hospital-based ERs. We've been unable to compel the state to create boundaries for this high-profit model, and have also been unable to successfully bargain a contract with the hospitals for their appropriate use. It's a frightening waste of limited healthcare dollars. We need structural solutions. These facilities should not be replacing urgent care and should not be licensed as the hospitals they are not. We've advocated for several solutions, including to be paid differently in urban areas than rural areas where they may actually serve a care solution, be paid based on recommendations in the MedPAC report of 2018, be required to offer urgent care on site, reimbursement to match urgent care rates when they're providing urgent care level of service, be licensed separately from hospitals to support community and residents rather than the hospital system that's frankly using Nevada to extract high profit dollars. They should not be built on top of each other or other actual hospitals. They should not be considered ER transport sites by ambulances. We're continuing to work with our member groups on other potential legislative options that have worked elsewhere. Patients don't understand that these facilities are not an urgent care, nor are they a full-service hospital, and that they can't perform surgeries or admit patients, among other limitations. We have found that patients don't understand that they're going to be billed hospital ED rates. Patients often seek treatment at freestanding emergency rooms for lower acuity care, such as upper respiratory infections or UTIs, which can be treated far more affordably at an urgent care. The cost differential between an urgent care and an emergency room is substantial, often 10 times higher to both the patient and the health plan. In addition, when a patient is experiencing a real emergency that requires admission or higher level care, the patient then finds themselves being transferred by ambulance to a larger hospital, often within the same system of ownership of the freestanding emergency room and away from their homes. We don't believe patient need is driving the rapid growth of these facilities in our community, but a quest for market share in high-income areas, an ability to open a facility with much lower cost structure and still be able to bill at full ED rates, even for lower acuity cases that can be treated more cost effectively in an urgent care facility. The community needs investment in primary care and the establishment of 24/7 urgent cares to reduce high-cost ED visits that divert precious healthcare dollars away from services we truly need. The unchecked growth of expensive freestanding emergency rooms happens in states without a strong regulatory structure. And as a state, we need to focus on incentivizing access to high-quality, affordable care that Nevada's needs. We look forward to working with you as you perform your analysis of their impact and are happy to answer any questions you may have for us. Thank you.
Great, thank you. And next we have Clarence Dunnigan.
Hi, I'm the chairman of Mountain View Hospital, but I do have a unique perspective. I've been here since 2004. I was in the Air Force. I was at the VA. I see Sam Kaufman on here. He and I had breakfast together at Blueberry Hill back in like 2006. The reality is our ERs are getting overrun. My ER averaged 220 patients a day last year. It's up to 250 a day this year, even with freestanding emergency departments. They are not urgent cares. They have all board certified emergency medicine docs. The community in Las Vegas need them. And if we didn't have them, my ER would be seeing 400 patients a day. So we absolutely need them. Thank you.
Great, thank you. All right, so let's see. With that, I'm going to move into the presentation on the study that the Health Authority is conducting. Okay, so as I mentioned earlier, my name is Madison Lopi. I'm the Chief Biostatistician with our Office of Analytics. I'm just going to go through, I think, some background, although we've heard quite a bit on the phone about the topic, where some of the healthcare facilities are in Nevada, some preliminary Medicaid data that we have, what approaches other states have taken, and then next steps for our analysis. So as you all know, freestanding emergency departments have become increasingly popular in the US, including in Nevada, which is why we're here discussing this today. FSEDs do increase healthcare utilization. However, a large share of the visits are often non-emergent conditions. One study from United Healthcare showed that the cost of services for these conditions was 22 times more in an FSED than in a physician's office and 19 times more than at an urgent care center. Additionally, FSEDs are typically located within urban areas that are within a close radius to hospitals as compared to rural areas. So given some of that information, the Nevada Health Authority is doing an analysis to look at the cost of care in freestanding emergency departments compared to a hospital emergency, the frequency and the cost of care for non-emergent visits in an ER, and then where the freestanding ERs in the state are located and how do they address access to care. So I apologize if these maps are a little small and hard to see, but this is the locations of the healthcare facilities in the Reno and Las Vegas areas. Just to give a little bit of context of where freestanding EDs, but also other facilities are in relation to each other in our urban areas. And I will note that these are back from early 2025. So some of these facilities may have closed or some may have opened. So there may be some changes to this, but just to give a general idea of the rough location of the facilities. So first off, let's just start by looking at general FSED utilization. This is among Nevada Medicaid specifically. So you can see this chart here on the left shows the paid amount to FSEDs and the total number of visits from 2021 to 2025. As you all know, there has been exponential growth in the utilization of these facilities, largely just because as more facilities open, of course, that's going to increase utilization. So we've seen such a significant increasing trend, and we'll continue to see that as more facilities are opened. Interestingly, on the right here is a list of the top 5 diagnoses in these facilities in 2025. So of course, every visit, every diagnosis, every reason, every person is different. However, the large share of these may be non-emergent conditions that could potentially have been seen at an urgent care or in a non-emergent setting. So to give some context on the cost comparison of freestanding EDs, this chart shows for those past 5 diagnoses that we just looked at, the comparison in a hospital ED and a freestanding ED. Most of them, 3 out of the 5, are pretty comparable between the two. There are 2 urinary tract infection and headaches, where typically those cost more in a hospital ED as compared to a freestanding ED. I did want to note that typically evaluation and management on average costs about 3% more at an FSED than a hospital ED. So their initial evaluation upon a visit may be more expensive in a hospital setting. However, when looking at these top 5 diagnoses, they're either comparable or less than in a hospital ED. And this page goes into specifically non-emergent conditions. So for this information, this is looking at just 10 non-emergent conditions based on the diagnosis that was billed on the claim. But the reason is to show the percent of visits that are non-emergent in each of the 3 settings: a hospital ED, freestanding ED, and urgent care. So a hospital ED makes up the lowest or has the lowest share of non-emergent conditions at roughly 20% of visits. A freestanding ED has 27% of visits that are non-emergent. And an urgent care has the highest percent at roughly 35%. And the chart here over on the right shows the cost of the visits. So freestanding EDs, historically for these non-emergent conditions, these 10 specifically, have been continuously lower, but fairly comparable to a hospital ED. Whereas, of course, care for these visits in an urgent care setting is quite a bit less. And then this page, I just wanted to mention some of the approaches that other states have taken to kind of address any utilization of an FSED for non-emergent services. One of them, and I think has been mentioned already, is education. Educating the population on the difference between services that are provided in urgent care versus an emergency department setting. This could be at population level education. Some facilities have also added like signing or something that really indicates and calls out on the facility itself to indicate that it's an emergency department and not an urgent care. Another approach that some states have done are cost-sharing adjustments, where patients would pay higher copays for non-emergent ER visits, encouraging them to choose urgent care when applicable, when available, when it best would suit their needs. Another option is acuity-based models. So payments are tied to the severity of the condition. Lower acuity visits would have lower reimbursement, and vice versa for higher acuity visits. And then last, what some states and facilities have done is to offer a hybrid model where both urgent care and ER services are under one roof in the same facility, and then the patient can be triaged upon arriving at the facility, therefore in turn reducing unnecessary ER billing. So next steps for the health authority and for our analysis is we're compiling all of the information. It just gave some high level overview, but comparing what the cost of a freestanding ED is in relation to a hospital ED and in comparison to receiving services for non-emergent conditions in an urgent care. We're holding this public workshop today to get any input on this study specifically, any suggestions, any thoughts, data sources, maybe that would be helpful for us to consider. And then we will work on or finalize compiling the report that will be available by the end of summer. So with that, I'm going to open it up for additional discussion and any input specific to the analysis.
Hi, Mary. This is Dr. Kavita Batra from School of Medicine for Records. Thank you for sharing this analysis. Are you also planning to do more sophisticated analysis in terms of return on investment analysis, like how many lives were saved in those point of view? Number of yeah.
We have discussed looking at like outcome of services in different settings, follow-up care. So depending on time constraints are discussing including that in this analysis.
Okay, and then if there are several agencies and doing some sort of intervention, how will you compare whether those interventions specific to that facility working or not in terms of outcome evaluation?
So Dr. Batra, I think the challenge is we have limited data still. We don't have our APCD yet, so we're using Medicaid data. So we're doing the best we can with very limited data.
Okay, thanks.
Thanks, though, it's helpful. Once we have APCD, we can look at more broadly the care models that are going on in these facilities.
Sounds good.
Thanks.
Let's see, Sam, go ahead.
Hi, this is Sam Kaufman. I'm the CEO of Henderson Hospital, representing the Valley Health System. Been in the state for 35 years, and we own and operate 9 of the FSCDs located in the city and the community. I did have a question regarding your data and the beginning of the study. Are you taking into account that hospital EDs will, of course, have a higher acuity level because of the number of ambulance visits that obviously are designated through destination protocols through the health district and such, where an FSCD probably sees less than one ambulance visit a day, which of course is going to drive acuity to a lower level and show that the lower level types of cases are more seen in an FSCD versus a hospital ED. So it would be my opinion for you to remove those ambulance visits for your overall denominator, because it does skew the data very seriously. And also keep in mind, I know there's a lot of discussion between the urgent cares and the FSCDs. To my knowledge, there's not very many urgent cares that are operational 24/7 in this town. And to my knowledge, none of the insurance carriers have 24/7 urgent care. So that may be an option for them to do something with that to better educate their clients. And also, there is reporting that we do for every single patient by state statute that requires us to submit a document to each patient that visits one of our FSCDs, and we follow that to a T, that explains to them that they are visiting an FSCD and not an urgent care center, and applicable ED rates will apply because of a higher acuity, because of the 24/7, 365 physicians, because of the CT scanning and other pharmaceutical and other radiologic types of modalities that are not used in urgent care or physician practice. Thank you.
Thank you. I appreciate that. And just to address some of your comments, yes, we are planning to account for acuity and considering that in the data. And then also the availability of 24/7 care is something we've discussed as well, that sometimes there may be instances where an urgent care is closed or unavailable, and reasons why somebody may go to an FSCD for apparent non-emergent conditions.
And also one last thing, if I may, you may want to take a look at the main hospital emergency rooms, which I believe there's 14 of them in town, and the overcrowding that these emergency rooms have had over the last 8 to 10 years before the advent of the FSCD. And we've actually been able to level load some of the volume out of our emergency rooms and basically reduce our wait times for our patients, which is better for acuity, better for patient safety to reduce their wait time so our patients can be seen quicker. And by having the FSCDs and more access, we're able to do that not only with Valley Health System, but HCA and Dignity as well. Thank you.
Thank you. Any other comments or input for the study? Yes, go ahead.
Hi, Dr. Justin Semsrott, SCMP SROTT with Team Health. As far as I understand, the urgent care centers are not bound by EMTALA to provide stabilizing treatment and can require payment upfront, as well as verification of insurance. And the freestanding emergency departments are obviously bound by EMTALA, filling in a gap for those unfunded patients. I know that the data and the study that you all are doing is based on Medicaid data. So will there be an analysis of private insurance as well as unfunded patients and how the freestanding emergency departments impact care in those communities as well? Thank you.
I'll take this, Maddie. We, again, only have access to the data we have, and we were asked to do this study now. So we're doing the best we can. When it comes to considering those other, if they're uninsured, I mean, come on, no one's getting paid for that service. So private market's a little different. I think we're going to take feedback from carriers on some of that and their experience as well in that space. But we have to look at it from a state budget perspective. That's the request that we were given. And that is why we're doing this study, because we do know it is driving up costs in our programs, including the public employee benefit program. So we have to take that seriously because we still have to have programs that are sustainable. The EMTALA issue, we are working with some partners at Georgetown on a unique interpretation of EMTALA that does allow you guys to triage. And so I don't think we can just say that just because you build an ER and someone pops in that you have to treat them added as they're an emergency if they're not. And those are the cases we're most concerned about because of limited funds. So I just want to point that out. We will be looking at as much data as we can and doing interviews again with carriers as well as providers. Go ahead, Maddie.
Also, just want to add to that some of the information. Currently all of the information that we have in that PowerPoint is based off of claims data. So if it's not something that's billed on the claim or tangible to see on a claim, unfortunately, that's information we may not have available for this study without additional sources. Any other comment or input?
Maddie, we
Crystal,
may have lost your, oh, sorry. Go ahead, Crystal.
Hi, Dr. Crystal Turgis. I wondered as well, working at both the freestandings and the main ER, I get an abundance of Medicaid patients in the main ER that also have low acuity complaints. I wonder in your analysis or in your data, if you're looking at both freestanding presenting patients with Medicaid insurance with low acuity, as well as the way they will still similarly show up to the main ER with their low acuity complaints.
Yes, so we would be comparing, we're trying to compare similar acuity, similar situations, similar conditions in the different settings. Any other comment or input?
Maddie, I'd like to ask a question of the group, since many of you are in other states and for-profits that operate all over the country. I'm curious if other states have creative models that you can live with on trying to ensure that ER visits are actually emergency and that we're paying appropriate care, appropriate setting. So I'm just curious if any of you have examples of states that are doing it well and their strategies that balance everyone's needs. I know that's impossible sometimes, but just curious if anyone here has some of those examples. And if you don't have them today, we're open. We'd love to see those examples because without your feedback on that, we're going in blind and finding them ourselves. So if any of you like HCA or UHS or any of you that have hospitals in other states have strategies that we should look at, that would be helpful.
Hi, Stacy. This is Jackie Van Blerkum with the HCA. And across many of our states, and similar to what we're doing here locally, we have a 24/7 nurse advice line that we promote in every care setting, in our urgent cares, in our hospitals, in every one of our discharge instructions. And we encourage our patients to use that nurse advice line. Point in fact is that we've been able to triage many patients to a primary care physician. We also have a opportunity to find people a primary care physician through this nurse advice line and schedule patient appointments. We also have urgent cares that we put right next to our freestanding emergency rooms within a mile of these freestanding emergency rooms. That's critically important to us. And then we are changing out all of the signage across the entire enterprise to make sure it is crystal clear that these are ERs. So those are some of the things that we do. And, we staff these with 24/7 emergency room physicians. We have CT scanners. These are full-fledged emergency rooms. You heard the incredible stories from some of the physicians, but we're happy to work with you on sharing other things that our other HCA states do to make sure that people are accessing these appropriately.
That's really helpful, Jackie. Thank you. Yeah, if you guys want to, when you do your formal public written comment to us, if you want to include some of those, and then we can definitely include those in some of our recommendations in the report. Thank you.
Thank you.
I do have a comment. I just want to point out I do work here in Las Vegas, and we do get, and I don't know if this is going to be a statistical analysis, we do get a lot of urgent care patients that are coming straight to the ER as they're told, which is a good thing for us to evaluate them. Will that be taken into consideration? Hey, they went to an urgent care, they were told to come to an ER, to a freestanding ER, because their complaint was more than urgent care needs.
Yeah, it will be taken into consideration. I actually had that happen recently to myself and my son, and it was not an ER visit, and I got a $4,000 bill. So we are definitely looking at that issue of why people are referring people that should be urgent to freestanding ER. So yes.
Thank you.
Any other comment or input from the group?
Stacy, it's Jeff Morosky for the record. Just want to ask to clarify on that last comment. I think what the physician was asking is, can we take into consideration looking for patients who have an urgent care charge the same day as a freestanding ER charge? Because we do get a number of patients where they go to an urgent care and then are directed to an ER or a primary care office and are directed to an ER for what seem like low-level complaints that may have a concerned headache, while a low-level complaint can be something very serious and many times has a warning sign, but the complaint is still headache. And if you rule out the common conditions, you end up with that low level charge. So I think looking at that as well, was there an ER or a primary care visit same day, might help understand what's driving that visit.
I agree, Jeff, but I will be honest with you, what I personally experienced was, and I'm not going to name the hospital here, but I personally experienced someone sending me to a high cost care when it was urgent. So, and being referred around to and getting billed the higher rate when I did not, there was clear to me, we did not need to go to an ER, but that was the only place my son could get an access to service. And it really was an urgent. My husband's a physician. So I hear you, Jeff, but we're going to be looking at all kinds of business practices too in the data of inappropriate referrals as well. And because that kind of stuff is not okay. And I think it goes against all the good work that some of you are trying to do at these ERs, right? So we're looking at both sides of that.
Yeah,
these referral
totally
patterns.
agree.
Yeah.
Yeah, we don't
No,
we don't
I
want to
just
see
want
those
you to
patients
know,
in our
like,
ER either when
yeah,
they're
no, I
referred in
hear you though.
appropriately. That's
Yeah,
what we're looking for.
exactly. I think we all want that, and it's just, I don't think we're trying to say that freestanding ERs don't play a role. They do. And I mean, you could hear the stories and we know that. Some of us even have personal experiences where they have played an important role, right? But I think the challenge that we're seeing in the data is the cost and some of the inappropriate care that is occurring in these settings. So that's what we're trying to figure out, how to prevent that and to support those that are doing it correctly in a way that's really getting at the ER emergency needs. So thank you. I see Babette's hands up. You want to go, Babette?
Thank you. Babette Bond, I've joined late. And so this may be repetitive. Thanks for the time. First of all, thanks for doing this. I'm glad that there's a study going on. And second of all, I think Stacy probably offered the coalition support in what just came up about commercial data. And if there's a way for us to do that through the coalition, we'd like to support that. Third, I think that what I didn't hear yet is the impact that the combination of really high coding, level 4, level 5, level 6 coding, which is not the same bell curve that we used to see, is something that I hope that you're taking a look at, the high end coding that we see in some of the facilities. And we've spent a lot of time on that. And then I think the impact, the double impact of the high coding and what's happened with IDR, where groups like Team Health are, really spending a lot of time appealing decisions to IDR, and it's driving up those ER costs too. I don't know if there's a confluence there that would be like you'd have a chance to look at. I don't know if you guys even engage in IDR, but we do. So that's a third thing that's really impacting our ER rates. And see, I'll come back if I have more. I'm just trying to catch up here. Thank you.
We'll definitely take you up on the
I'm
data.
sorry.
Yeah,
There was one more. It was the practice patterns. I think that we noticed, and we didn't know this till recently, that there are emergency medical staff, not emergency room, but the ambulance, the actual ambulance is recommending people go to the freestanding ER instead of an emergency room. And we have always thought that the EMS transport situation was not something that was going to be so extensively, moved into the freestanding ERs because they really can't take care of patients in a lot of conditions. So we wonder what your experience is with that too. We're seeing that now. Thank you.
Maddie, I see you're taking notes. We'll follow up too, Babette, and see what data we can get, because that would be really helpful. We're also going to do our best if we can get access to our public employee benefit data more to look at some of this as well, so we can compare.
Okay.
I see another hand, a couple hands. Todd, I don't know if it was you or Dr. Shear that was up first, so I'll let you guys battle and decide.
Go ahead, Dr. Shear.
Thanks.
Sounds good. I just wanted to, clarify the team health and the IDR. Team health has been successful in IDR 93% of the time, which usually means that 93% of the time you're underpaying us. That's what 93%.
I beg to differ that that's what's happening with IDR. There's a lot of national work coming out now explaining the rates that are being charged instead. And because it's a baseball arbitration process, there is a real trend of super high payments way beyond anything that ever happened before. And this is not the meeting for that, but I did want to get it on the docket because we are talking about ER payments and ER costs.
We at Team Health have never balanced bill anybody. So that's just another point, but independently 93% win rate is something to be said.
Yeah, that's a problem.
Todd, you're up.
Yeah, hi Stacy, Todd Spenberg, Sunrise Hospital. When you look at your data, and the discharge, the 5 diagnoses you share, was that chief complaint or discharge? And are you going to look at both of those when you pull the analysis? I think we all know, when a patient seeks emergency care, they could be having a heart attack, and it may be coded on the back end, as indigestion, and I'm the last one clinically to go through all that criteria. But I think it's important that in the analysis that we understand what they're coming in for and not just relying on discharge data for the analysis. So hopefully we could look at both or the initial complaint when we do the analysis.
Yeah, thank you for flagging that. Very interesting. So the diagnosis that's on there is the principal diagnosis as it's billed on the claim. But definitely interesting for comparison. We'll consider that. Thank you.
Dr. Evans, I see you're up.
Hi, yes, I just wanted to clarify something. My understanding from your studies or the information that you have so far is that the data you have is from Medicaid, Medicare. And I just want to clarify if it's naive, but most or like Medicare and Medicaid don't have copays for ER visits, is my understanding. Is that correct?
So just to clarify, it's not Medicare. We do Medicaid and we cover 1 in 4 people in the state. So, and we do not have copays at this time, but we will soon under the HR1 bill that passed at the federal level for adults without children.
Oh, okay, because that might like skew the types of visits also that we get for the ERs as well, without the copays, because I came from a like very middle income family. We didn't go to the ER virtually ever, unless there was something very significant. So that might
Yeah, but that's the
add on
budget
into
problem.
the type of data that we have.
Yeah, and I
That's all.
appreciate that, but that's our budget problem, right? So, to make sure this is sustainable, we got to figure out a way if that is where most low-income families can get access to services, which shouldn't be. That's why we have Medicaid managed care to create networks so they can have other places. And the care line was a great example that Sunrise is using, I think, as a way to triage and help people find care. But it's affecting budgets, it's affecting state costs, and our program just went up 14%. I mean, I can tell you right now, our budgets aren't pretty, and next session is coming. And I am concerned. And so that's why we're doing the study. And it's really about Medicaid, which is like the largest budget in the state for the state budget, the largest portion of the state budget. And it's growing. So I appreciate the perspective on that. But I think from our perspective, that is and why we're studying this. And maybe I'm not understanding, Dr. Evans. Sorry.
Oh, no. It was more just a question. Thank you.
Yeah, no problem. If we could do copays and steer people, we would, but honestly, that's not really helpful to these families. Daniel, I see someone's hand up. Sorry, Maddie, I'm driving. You can drive again.
Hey, Stacy, Daniel Lamas
Hey.
with HCA Healthcare. Nice to see and hear from you again. I wanted to add a couple additional areas that we're focusing in on the FSEDs here within HCA. I know Jackie talked a little bit about the nurse navigation lines and really kind of helping navigate that care to the right location. In addition to that, we have a significant amount of investment in the FSEDs to have discharge coordinators as well as care navigation. And really what we're focusing in on is those folks that are discharged from our emergency department that need specialty care are being navigated to those specialists. I think that's a huge opportunity for us to reduce the readmissions through our ERs. And with the lack of primary care, that's also something we help facilitate post-discharge. So it's not only specialty, it's really kind of helping the patient through the cumbersome process of finding a specialist. Stacy, I think you mentioned you visited an ER. I'm sure you had a referral as well. And navigating that referral probably wasn't the simplest without any help or navigation. And so we have a significant amount of investment where we have centralized and in-person navigation teams within HCA's ERs here in Las Vegas, main campuses and FSEDs to help really get those patients to the right specialist in the right amount of time. And that's very cumbersome with different payers and different authorizations and availability on these specialists, and primary care becomes quite different. But really our navigating team doesn't stop until we get them an appointment. And that's another important part to take a look at, what HCA is doing to invest in reducing the readmissions and overuse of our emergency departments across Las Vegas.
I really appreciate that, Daniel. It's some of the stuff that we're trying to do with many of the hospitals that are on here with the private hospital and MCO collaborative. One of the things that we're working on is a value-based payment arrangement that would reward you guys for some of that. So I hope, and I know that some of that transition, we're calling it transitions to care, but it really is to avoid that recycle. So hopefully you guys can benefit from that and some of the arrangements to get some of those shared savings, right, back to you guys. So, but thank you, Daniel, for sharing that. And we'll be looking at some of your strategies in our recommendations. So thank you.
I believe everybody with a hand raised has spoken unless you have any additional comment. Any other comment or input from the group?
Well, Maddie, before we chime off it, I just want to say thank you to everyone for being here and kind of helping us think through some of these thorny issues because it's not easy. I think, we all agree that the life-saving care is critical and we need access to that when we need it, especially in some of our rural areas that do not have access, right? And so just want to say thank you for that. And, we're trying to lay out, maybe we probably didn't do that earlier, but our goals is really to ensure access to appropriate care, right? And that's sustainable. And so I think any ideas that you have in that space, data that you want to share with us, as follow-up, we will review it. We have a full team that's working on this, so it's not just poor Maddie on her own here, even though she's amazing like that. But we also have a clinician, a clinical informatics physician from UNR that's supporting us as well. So I just want to say that, please, if you have other thoughts or if you want to really say that this, help us refine our goals and make sure we're not missing our goals, because often when we're trying to come up with solutions is to solve a problem, right? And our goals, the problem we're trying to solve is making sure that inappropriate care is appropriately triaged. So we're effectively using limited taxpayer dollars and not running our budget to, dry. So, but also ensuring that we're growing needs in the state for workforce and access. So feel free to send us those thoughts and feedback. And if you have the stories, the life-saving stories, please feed us those too, because I think those are the types of things we do want to make sure that in our report there is that conversation. So Maddie and Allie, is there anything else you guys wanted to add before we hop? Okay. Well, thank you all again for being here. And like Maddie said, the report's gonna be this summer, Maddie, correct? The draft?
Yes, by
Okay.
the end of summer. Yep.
So we'll probably post it for feedback and do a presentation. And I'm sure we'll have our 2-minute rule for that one because it'll be, I know, a lot. But again, we'll have written feedback. And then before we finalize it, we'll take all that feedback in and then we'll finalize it for the governor's office and lawmakers. Again, thank you for the time. And I hope you guys have a good rest of your day. Thanks. Thanks, Maddie.
Thank you, everyone.